Hi everyone, my name is Kávási Sarolta Beáta, and let me present to you my PhD topic, which is surgical aspects of colorectal cancer treatment. A few words about myself. I'm a fifth-year surgical resident in Toldy Ferenc Hospital, and I'm a second-year PhD student here at CTM. I have the vision of improving the immediate postoperative and quality of life of patients following colorectal cancer surgery, with the mission of bringing the latest scientific data to clinical use in this field. For this, I have two specific goals. Our first project is entitled End-to-End Anastomosis Provides Similar Quality of Life Compared with Other Reconstructive Techniques 6 months following total mesorectal excision. As we all know, worldwide there's an estimated 1.8 million people diagnosed each year with colorectal cancer, from which more than 700,000 cases are rectal cancer cases only. In Hungary, there's around 10,000 cases of colorectal cancer diagnosed each year. Anastomotic leakage, which is the most feared postoperative morbidity, is reported around 13% following 30 days of surgery and can increase up to 20% beyond 30 days postoperatively. Up to 90% of the patients undergoing total mesorectal excision will have low anterior resection syndrome, which will impair their quality of life in the long run. At this point, there's no clear consensus on which type of anastomosis is safer for a surgeon to perform. Thus, the aim of our study is to investigate which type of anastomosis is safer to perform in terms of postoperative morbidity and quality of life, and to assess if end-to-end anastomosis is as safe as the other types. For this, we have the clinical question of, does end-to-end anastomosis show any difference in terms of postoperative morbidity and quality of life compared with other types of reconstructive techniques? We have used the PICO framework, where our populations are patients following total mesorectal excision. We are comparing end-to-end anastomosis to side-to-end anastomosis colonic J pouch, and our outcomes are listed here. We hypothesize that end-to-end anastomosis is as good as the other types of anastomosis in terms of safety and quality of life. We have done our systematic search on the 8th of November 2022, and after a careful selection, we have narrowed it down to 27 eligible full-text randomized controlled trials. Let's talk about the most important outcome, which is anastomotic leakage. This plot represents the risk of developing anastomotic leakage following end-to-end anastomosis compared to colonic J pouch. This outcome, as I have mentioned, is very important to us as surgeons, because it is not only the most serious postoperative morbidity, but it is also the most expensive one to treat. For this, we have used the measure of effect of risk ratio, which can be interpreted in the following way. If the risk ratio is equal with 1, then there is no difference between the two types of anastomosis. If the risk ratio is smaller than 1, then there's a higher chance of anastomotic leakage in the colonic J pouch group. If the risk ratio is higher than 1, then there's a higher risk of anastomotic leakage in the end-to-end group. As you can see, we have included 15 randomized controlled trials in this analysis, and our heterogeneity is quite low due to the strict inclusion and exclusion criteria, and also because the total mesorectal excision is done on a very specific subset of the population. Here, the risk ratio is 1.03, meaning that the risk of developing anastomotic leakage is equal between the two studied arms. Similarly, we have compared end-to-end anastomosis to side-to-end anastomosis, and our risk ratio is 1.19, meaning that the risk of developing anastomotic leakage following end-to-end is the same or similar as after side-to-end anastomosis. Patients following total mesorectal excision will have a variety of dysfunctions, not only bowel dysfunction, but also urinary, sexual, and even psychological dysfunctions. That's why it is very important for a surgeon to check for the quality of life postoperatively. We have compared end-to-end to colonic J pouch in this analysis, and as you can see, we have checked our patients at 6 different time points, but actual analysis was done only at 6 and 12 months from 4 randomized controlled trials. We have used the standardized mean difference as the measure of effect because of the varied questionnaire used across all the studies, and this can be interpreted in the following way. If the standardized mean difference is equal with 0, then there's no difference in terms of quality of life between the two types of anastomosis. If it's smaller than 0, then there's a better quality of life in the colonic J pouch group. If it's higher than 0, then it's better quality of life in the end-to-end group. But as you can see in both time points, the standardized mean difference was close to -0.02. Both of them are statistically non-significant results. Similarly, when compared the end-to-end to side-to-end anastomosis, actual analysis was done only at the 6 months time point from 3 randomized controlled trials, and the SMD was minus 0.04, meaning that at 6 months following surgery, there's no difference between quality of life following end-to-end or side-to-end anastomosis. So what is the clinical significance of all of these statistically non-significant results? Well, actually, the side-to-end anastomosis and colonic J pouch are time-consuming, technically challenging, and sometimes requiring more staplers. So without any added benefit, we should use the cheapest, fastest alternative there is, which is the end-to-end anastomosis. The strength of our study is that actually it's the first quantitative analysis on quality of life following total mesorectal excision, but of course it has its limitation, as in lacking data and the varied quality of life questionnaires used. In conclusion, we can say that there's no difference in short-term postoperative morbidity between the 3 studied arms, and at 6 months following surgery, the quality of life of end-to-end anastomosis is similar as after colonic J pouch or side-to-end. So this is the status of our manuscript. We're waiting for result from scientific reports. It is under review at the moment. Let's talk a few words about my second topic, which is comparing surgical and oncological outcomes of extralevator to conventional abdominoperennial excision for low rectal cancer. As we all know, for advanced low rectal cancer, abdominoperennial excision is one of the standard surgical procedures at the moment, but it has a high risk of local recurrence, up to even 30% by some studies. For this, in 2007, Holm et al. Proposed the extralevator abdominoperennial excision, which is excising not only the rectum and the mesorectum, but also the surrounding levator muscles, hopefully leading to a better oncological outcome. But of course, this also has its downfall with the increased perineal wound healing and perineal hernia, which by some studies can be up to even 60%. So the aim of our study was to compare the morbidity and long-term effects of ELAP compared to APE. We have the clinical question of, is ELAP associated with increased overall survival rate and higher morbidity compared to APE in patients with advanced low rectum cancer? We have used, again, the PICO framework, where the population is the adults with advanced low rectum cancer. We are comparing ELAP to APE, and the most important outcomes would be the long-run oncological outcomes, such as overall survival, disease-free survival, and local recurrence-free survival. And we hypothesized that ELAP is associated with an increased survival time, but higher morbidity compared to APE. We have done our systematic search on the 14th of April last year, and after careful selection, we have narrowed it down to 32 full-text articles, and we have just started the data extraction. So in summary, we have these 2 projects ongoing. The first one hopefully will be soon published, and the second one, I hope in summer, will be published. And I want to thank you for your attention with my favorite quote: "It is not the strongest of the species that survives, nor the most intelligent. It is the one most adaptable to change."
Can you consider the preoperative oncological treatment in the second study and the second meta-analysis? Can you take it?
I hope so, but I think most of them get radiation. So for low advanced rectum cancer, it's a standard procedure to get radiation therapy. Not everyone gets chemotherapy, but radiation, yes. But of course, if it's possible, we'll try to exclude the ones who didn't.
Regarding the first, there was no difference in quality of life at 6 months.
Yes.
What do you think in a longer term? Will it differ or not?
Well, actually, up until now, the studies showed that in the first 2 years, there's a difference in quality of life. After 2 years, there's no difference. So what we try to prove is that actually this time frame is even earlier. You don't have to wait 2 years, but even in 6 months, the quality of life is comparable. So actually, we just made this time frame shorter with our study.
I have a question about your second study as well. So are you including only randomized trials in that case?
No,
or are they...
Unfortunately, there's only 1 or 2 randomized controlled trials. There will be mostly cohort studies and retrospective analysis.
Are there any differences in the patients that would be selected for these 2 types of procedures?
Yes, a bit, yes. Because, well, some of the studies are trying to somehow randomize them, but not like full randomize. So they're trying to equally divide the patients and have the same pathological or the same stage of the cancer in both. But some of the studies which are done retrospectively, they tend to have more severe cases in the ELAP group, the ones that would not benefit from an abdominoperineal excision. So that's a big bias. And
do you have any strategies to mitigate this problem?
I would just describe it, probably, but we'll see if the statistician have any idea. But
so I think you should definitely try to do a sensitivity analysis based on the study design. For example, if you have any matched studies, then you can do subgrouping based on, you know, retrospective versus prospective.
I will try to. I'm not sure if we have 3 randomized controlled trials, but that would be the plan.
But even if it's not randomized controlled trials, for example, if you have a very well-matched study, you can consider that different from the retrospective ones, for example.
Okay. Okay. Thank you so much.
And thank you for your talk. I may misunderstand things, but if I understood correctly, you're basically sort of approving a null effect, which is kind of tricky, because if you just include very limited amount of patients, that even from day 0 you can say that there is no statistical difference between the 2 groups. So how, did you manage to somehow sort of take a different perspective to actually show that it's not just you don't see a statistically significant difference, but you can sort of statistically prove that there is no medically substantive difference between the 2 groups?
It's a good question. I didn't think of it this way. I'm not sure if it's related to your question, but we don't only check for quality of life. We also checked for function, bowel function. But I really don't know how to answer your question, honestly.
Okay,
if you have any idea, actually, you can share with us.
Okay, so it's not easy to prove a null effect, but So I would probably not choose a frequentist kind of analysis, but sort of something Bayesian, a Bayesian meta-analysis, for example.